Good morning, everybody, and welcome to this important session of metabolic acidosis and lactic acidosis in cirrhotic patients. It is a complex problem of acid-base regulation in liver cirrhosis. Acid-base homeostasis is critical for normal physiology and cell metabolism, and essential cellular processes, metabolic enzymes, and transmembrane transport are highly pH sensitive. Normal arterial pH is 7.4, intracellular is 7.2. It is regulated by body buffers, lungs, and kidneys. And individual cells also have mechanisms to regulate intracellular pH. And liver is now recognized as an important organ of acid-base regulation. So we have to understand the basic mechanisms of renal physiology of pH maintenance, because the liver disease affects all these processes. So the production of endogenous acids and bases, endogenous acids, volatile acids, carbonic acid removed by pulmonary mechanisms, and non-volatile acids, sulfur-containing amino acids, phosphorus-containing amino acids, they have to be removed by the kidneys. And endogenous bases, citrate and lactate, converted to bicarbonate, and the vegetarian diet generates more bases than acids. And the hydrogen ion concentration in the body fluid is various factors affecting the processes that generate energy, that is metabolism, intake, digestion of food, renal mechanisms that we will see, and hemoglobin as buffer, and the respiration that immediately takes care of the maintenance of the pH. So the most important pH for the body is the intracellular pH. But the clinician is looking, the acid-base disorder, the clinician is always looking from the outside in. We use the extracellular results to make inferences about the intracellular conditions. The maintenance of normal pH by the chemical buffers, respiratory system, and the kidneys. Food intake, hydrogen ion generation, buffering, and that causes reduced bicarbonate, which has to be generated by the kidneys. Then the CO2 liberated, removed by the lungs, and the sulfate, phosphate, and chloride. The non-volatile acids are to be removed by the kidneys, that we will see. The buffers, they are the first line of defense. The bicarbonate mechanism by the kidneys, and PCO2 by the lungs. And the phosphate buffers regulate the intracellular pH and plasma protein, hemoglobin, and bone, that we will see. The regulation of acid-base balance, the hemoglobin main buffer for carbon dioxide, excretion of CO2 by lungs, reabsorption of filtered bicarbonate, and the excretion of fixed non-volatile acids by the kidneys. And the liver is considered important contributor to acid-base regulation, that we will see. The CO2 production from complete oxidation of substrates, metabolism organic acids, and ammonium, generation of urea, production of plasma proteins, and the bone buffers are very important. They can take up hydrogen in exchange for calcium, sodium, and potassium. Then renal systems fix hydrogen and bicarbonate. The reabsorption of bicarbonate filtered at the glomerulus, and the production of the ammonium, that is the proximal tubular mechanism, and distal tubular mechanism, net excretion of hydrogen and absorption of remaining bicarbonate. So the urine is free of bicarbonate. So 80% bicarbonate absorption in proximal tubule and thick ascending limb, and the cortical collecting duct, hydrogen secretion. This is maintained by the aldosterone system, is affected in the liver disease. Assessment of acid-base balance, we all know the arterial blood or mixed venous blood, pH 7.4, PCO2 40, and bicarb 24. Then there is a physical chemical acid-base approach. This is more complicated, but it states that even with the normal pH, if we calculate the anion gap and the strong iron difference by this method, then we can know the acid-base disturbances occurring even when the pH is normal. So this takes into account sodium. There is a marker of plasma dilution or concentration, that is 140. Then bicarbonate, albumin, lactate, and unmeasured anions and chloride anions. Metabolic acidosis, pH is low, bicarbonate is low, and the anion gap is sodium minus chloride plus bicarbonate, that is around 10. Then metabolic acidosis, normally in the physiological situation, the cations sodium 140, chloride 106, bicarb 24. So the anion gap is 10. It consists mainly of albumin. Now in renal tubular acidosis, the anion gap is normal, but the chloride absorption is increased. So it is hyperchloremic metabolic acidosis. Causes are renal tubular acidosis or GI loss of bicarbonate. While the high anion gap metabolic acidosis, the bicarbonate and chloride remains normal, but the anion gap is increased. That consists of ketoacids, lactic acidosis, acute renal failure, and toxins like methanol. The physiological role of healthy liver in acid-base regulation. The maintenance, the liver is the main consumer of lactate, around 70%. The lactate is converted to pyruvate. The glucose, pyruvate can generate again glucose by neoglucogenesis in the liver and release of bicarbonate. Albumin synthesis. Albumin is a weak, non-volatile acid. Reduced synthesis of albumin in liver disease leads to mild metabolic alkalosis. Then ketogenesis and keto acids produced in the mitochondria when carbohydrate and fat are incompletely oxidized and controlled by a feedback mechanisms. That is the keto acids, if the pH is low, keto acid production will be low. And the urea production by the liver, it's a detoxification process. Ammonium is converted to urea with consumption of bicarbonate. So the acid-base disorders in liver disease, the lung, liver, kidney crosstalk. In liver disease, the pulmonary mechanisms of acid-base balance are affected, as well as the renal mechanisms of acid-base balance are affected. Disturbances of acid-base balance in cirrhosis is a neglected issue warranting further insight. Just finding a normal arterial PLU and serum bicarbonate concentration in a given patient does not mean that no acid-base balance or disturbance is present. On the contrary, such an apparent normality may be the result of different abnormalities effacing each other, that we will see. So acid-base balance in disorders in liver disease is an important regulator of acid-base homeostasis. Respiratory alkalosis is a common acid-base disorder. It's many coexisting metabolic and acid-base disturbances are occurring. In stable CLD, several offsetting acidifying and alkalinizing metabolic acid-base disorders, hypoalbuminemic alkalosis, which is balanced by hyperchloremic and dilutional acidosis, and in critically ill cirrhotics, and acute liver failure, increased lactate. There is no overt acid-base disorder because it is compensated by the hypoalbuminemic alkalosis. So the alkalizing factors in patients with cirrhosis, respiratory alkalosis, and hypoalbuminemic alkalosis, low albumin. Mechanisms of hyperventilation and respiratory alkalosis in liver disease, which is the common metabolic disturbance. The reasons for hyperventilation are hyperammoniemic hepatic encephalopathy, estradiol and progesterone hormonal imbalance, dyspnea from the hepatopulmonary syndrome, portopulmonary hypertension, hepatic hydrothorax, elevated diaphragm, and atalaxis due to large volume ascites. Acidifying factors in patients with cirrhosis, hyponatremia, that is dilutional hyperchloremic acidosis, diarrhea, GI bicarbonate loss, RTA type 1 defect in distal tubular hydrogen secretion, impaired distal sodium delivery, inadequate chloride, spironolactone type 4 renal tubular acidosis leading to hyperkalemia, and saline-induced hyperchloremic acidosis. Pathogenesis of hyponatremia in cirrhosis: because of the splanchnic vasodilatation, effective arterial volume is reduced, leading to renin-angiotensin aldosterone activation, sympathetic nervous system activation, leading to renal tubular sodium and water absorption, edema, and non-osmotic ADH release, leading to impaired renal free water excretion, leading to hyponatremia. So it is a dilutional acidosis. And what are the reasons for hyperchloremic metabolic acidosis in patients with CLD? The chronic respiratory alkalosis as a compensation, reduced tubular hydrogen ion secretion, then hepatic encephalopathy, lactulose overdose causing diarrhea, bicarbonate loss, massive alcohol abuse, cholestatic liver disease and Wilson disease, renal tubular acidosis type 1, defect in the distal tubular hydrogen secretion causing high urinary pH, then spironolactone therapy, renal tubular acidosis, hyperkalemia type 4, therefore reduced ammonia production, and large volume saline infusion. All these factors lead to increased tubular chloride reabsorption, leading to hyperchloremic metabolic acidosis in cirrhosis. Then acid-base status in chronic liver disease approach. In stable cirrhosis, the low albumin level leading to metabolic alkalosis, they are balanced by the acidifying factors, that is unmeasured anions, low sodium, and increased chloride, hyperchloremia. But in critical illness, this low albumin, hypoalbuminic alkalosis cannot balance low sodium, and lactate is added, unmeasured anions, and increased chloride. So in critical illness, the balance tilted towards metabolic acidosis. While in acute liver failure, the low albumin, hypoalbuminic alkalosis is balanced by the lactate. So usually there is no pH abnormality. In advanced cirrhosis, variety of acid-base disorders, so then extra advanced liver disease itself, acid-base disorders, plus associated extrahepatic organ dysfunction in cirrhosis, encephalopathy, renal dysfunction may also cause or aggravate acid-base disorders. So the complications in critically ill cirrhotic patients: development of ACLF, increased cardiac output, hyperdynamic circulation, reduced systemic vascular resistance, reduced oxygen extraction, impaired tissue perfusion, splanchnic vasodilatation, reduced effective arterial volume, renin-angiotensin aldosterone activation, renal vasoconstriction leading to AKI, and septic shock, lactic acidosis, liver becomes a net producer of lactate. Then adrenal insufficiency is common, and elevated unmeasured anions associated with AKI. So there are adaptive mechanisms in cirrhosis. There are delayed or missing lactate clearance associated with prolonged acidemia, lactate affected, and susceptibility for extracellular edema, ascites, and pulmonary edema, complicating fluid resuscitation and therefore restoring kidney function. While in healthy liver subjects, adaptive mechanisms, rapid clearance of hyperlactatemia by liver leading to improved lactic acidosis and more aggressive fluid resuscitation, potentially improving unmeasured anion acidosis. So in cirrhosis, coexisting respiratory alkalosis partly compensate for metabolic acidosis, critical illness, lactic acidosis, marked hyperchloremic acidosis, ACLF. We have seen it is balanced. So liver becomes a net producer of lactate during hepatic parenchymal hypoxia. So disequilibrium in acid-base status in critically ill patient with cirrhosis, ACLF, and without CLD. So in ACLF, there is marked lowering of pH, low bicarbonate, associated lactic acidosis, and unmeasured anions. Association of bicarbonate and pH with 28-day mortality in critically ill patients with cirrhosis. So the low pH was associated with high 28-day mortality, and similarly low bicarbonate was associated with high mortality. The importance of different risk factors in patients with metabolic acidosis. 41% 28-day mortality associated with increased INR, increased lactate, high bilirubin, low sodium, and low pH. Acid-base status and its clinical implications in critically ill patients with cirrhosis, acute on chronic liver failure and without liver disease. Cirrhosis and especially ACLF are associated with metabolic acidosis and acidemia owing to lactate and unmeasured anions. Acidosis and acidemia respectively are associated with increased 28-day mortality in liver cirrhosis. Lactate and unmeasured anions are main contributors to metabolic imbalance in cirrhosis and ACLF. So in metabolic acidosis in critically ill cirrhotic patient with AKI, the unmeasured anions like the sulfur phosphate, they are added and there is A. Now, lactic acidosis in cirrhosis is a complex disturbance lactic acidosis is a common finding in ICU patients with cirrhosis who are admitted with gastrointestinal bleeding, hepatic encephalopathy, AKI, respiratory failure, and sepsis. So most lactic acidosis is the most common cause of metabolic acidosis in hospitalized patient and is associated with high mortality. Normal plasma lactate is 0.5 to 1.5, less than 2. Acute lactic acidosis when lactate is more than 4, blood pH is less than 7.35, and bicarbonate is less than 20. So hyperlactatemia, lactic acid, there is net addition of lactate and protons, that is hydrogen ions, to body fluids. So the high lactate level is associated with mortality. Basal lactate production is around 1,300 millimole per hour, per day. In the lactate metabolism, liver consumes around 60% of the lactate produced in the body, and it has a tremendous power of lactate utilization, so that even 50% of hepatectomy, the plasma lactate levels remain normal, and the muscles utilize lactate and the kidneys around 30%. So in chronic liver disease or cirrhosis with the metabolic acidosis, when there is associated acute kidney injury, this 30% metabolism or consumption of lactate cannot occur. So in AKI, the lactosis is enhanced. So lactate elimination is by chorecycle, glucose, anaerobic glycolysis, lactate production, which is utilized by liver by gluconeogenesis. So lactate, is it a useless end product or essential fuel? Lactate is a stress fuel used by the heart and brain, but it generates low calories. As we will see, the glucose metabolism in presence of aerobic metabolism, generation of pyruvate, acetyl coenzyme A, Krebs cycle, and high energy electrons, high energy efficiency system leading to CO2 and water. So CO2 released by the lungs. While in anaerobic metabolism, pyruvate is converted to lactate, which is without adequate oxygen, it's a low energy generating system. But liver pyruvate can be converted to glucose in neoglucogenesis. Causes of lactic acidosis type A tissue under perfusion hypoxia in various states of shock. Type B, absence of hypotension and hypoxia, hereditary enzyme deficiency, drugs, metformin, and various other drugs, isoniazid, systemic diseases, liver failure, and malignancy. So pathophysiological effects of severe metabolic acidosis, pH levels less than 7.2, various cellular mechanisms are disrupted, leading to increased apoptosis. So cellular and functional consequences in myocardial and vascular smooth muscle cells in severe lactic acidosis, various mechanisms are affected, leading to apoptosis and reduced inotropism, hyporesponsiveness to catecholamines, arrhythmia, and altered vasorelaxation. So management of lactic acidosis in sepsis or low flow states, mortality is more than 60%, prompt resuscitation is required, and treat the cause. Role of base therapy when there is severe acidemia, it may impair cardiovascular functions and blood flow, hence the need for base therapy to correct the cellular function. Role of sodium bicarbonate, most commonly used base, hypertonic or preferably isotonic, should be individualized to keep blood pH around 7.2, can improve cardiac contractility and restore responsiveness to myocardium to catecholamines. But the potential harms of bicarbonate therapy, in majority of studies, there is no reduction in mortality. In generation of carbon dioxide leads to intracellular acidosis, acceleration of lactate generation, reduced ionized calcium, worsen tissue oxygen delivery, hypernatremia, extracellular volume expansion. So adverse effects may be minimized by hyperventilation, CO2 washout, and by calcium infusion. Bicarbonate reduces ionized calcium level. So alternatives to bicarbonate therapy, ringer lactate, the lactate and acetate in presence of liver disease cannot be converted to bicarbonate, and the use of ringer lactate as a base in ongoing lactic acid is not rigorously examined. Plasma light, the calcium is absent, and in liver disease, acetate cannot be converted to bicarbonate. So alternatives to bicarbonate therapy, the dialysis, effective method to deliver large quantity of base in a slow fashion, better control of extracellular volume and osmolality, sufficient calcium may be added, acidemia may be corrected, and lactate is removed by dialysis, but the quantity reduced is small as compared to quantity generated. Can remove toxic alcohols and metformin. Which modality of dialysis, intermittent hemodialysis or CRRT, depends upon the facility available and hemodynamic status of the patient. CRRT delivers sodium bicarbonate at a lower rate with fewer adverse events in patients with hemodynamic instability, and CRRT is preferable in AKI with hepatic encephalopathy because it's a slow form of dialysis. But the trials of CRRT mostly non-randomized with low statistical power. So two main indications for CRRT are hemodynamic instability and hepatic encephalopathy. So surviving sepsis campaign, international guidelines for management of sepsis and septic shock in renal replacement therapy, either CRRT or intermittent renal replacement therapy can be used in patients with sepsis and AKI. CRRT is to facilitate management of fluid balance in hemodynamic unstable patient, and we suggest that against the use of renal replacement therapy in patients with sepsis and AKI for increase in creatinine or oliguria without other definite indications for dialysis. So dialysis should be used when there are indications for dialysis. The largest multicentral RCT enrolled 360 patients and found no significant difference in survival between the continuous or intermittent hemodialysis groups. So the algorithm, lactate more than 4, type A lactic acidosis, shock, regional ischemia, fluid responsive, yes, give fluids, not And superior vena cava oxygen more than 70%, yes. Consider vasodilators. No. Optimize oxygen delivery if hypoxemic. Increase arterial oxygen saturation more than 92%. Anemia. Increase hemoglobin blood transfusion. Myocardial dysfunction. Consider inotrophs. Increase oxygen demand, pain, agitation. Treat the underlying cause. Type B lactic acidosis due to liver disease, medication, malignancy. Treat the underlying cause. Then ILBS data, January 21 to November 21, 11 months, all liver coma ICU patients out of 605 patients were analyzed requiring 105 CRRT sessions. In 105 patients, 87 males and females 18. Causes of CLD, ethanol was the commonest cause. Percentage of patients with AKI, 87% patients had AKI who required CRRT. Percentage of patients having metabolic acidosis and lactic acidosis, both 60%, lactic acidosis 40%. ABG values pre and post CRRT, not much difference in bicarbonate level, lactate level, or pH. Other parameters pre and post CRRT, urea level increased, creatinine remains same, bilirubin same, INR increased. The outcome, 79% patients expired. So high mortality in patients requiring CRRT in liver coma ICU. So the lactate clearance and metabolic aspects of continuous high volume ultrafiltration, hemofiltration, compared with reported rates of lactate overproduction in septic shock and rate of lactate clearance is quite small. CRRT with high volume hemofiltration is not effective for severe lactic acidosis. Lactic acidosis alone should not be considered as a non-renal indication for CRRT. Means in patients requiring CRRT who are having sepsis, hypercatabolism, and lactic acidosis, the lactate generation is more than what can be removed by dialysis. The way forward, the basis for future research should include are dysfunctional mitochondria the common link between deranged organ crosstalk in liver failure, and what is the role of neuroendocrine and inflammatory mechanisms in the adaptive or maladaptive metabolic response occurring in liver disease, and what is the role of iatrogenic lung injury by volume overload, overtransfusions in these patients. So take home message, liver acid-base homeostasis by lactate clearance and albumin production, stable cirrhosis, equilibrium between acidifying and alkalizing metabolic acid-base disorders leading to normal pH. The normal pH does not exclude metabolic acid-base disorders in patients with liver disease, and hepatic decompensation in critical illness leads to metabolic acidosis and high mortality. A dysfunctional liver in sepsis may become a net lactate producer. Identifying acid-base disturbance is critical for therapeutic decision making. When there is metabolic acidosis, a washout of CO2 in the patient with ventilator, then correction of ionized calcium by giving calcium. So life is a struggle against the hydrogen ions. Thank you.